The primary care physician shortage is worsening. The HRSA's Bureau of Health Workforce estimates that America needs more than 40,000 physicians to meet our current needs. By 2037, the shortage is projected to be more than 87,000, and rural areas will continue to be hit hardest by this deficit. One possible solution that's been brought to the table by the Association of American Medical Colleges is to fill in the gaps with physician assistants and nurse practitioners. While we've seen a surplus of these positions, critics argue that it's not the one-to-one replacement many believe it to be. Dr. Christian Giordano says this is an ignorant assumption that's offensive to the value of PCPs, and one that could very well contribute to the worsening burnout these physicians experience.
I think when an article comes out like the AAMC writes that says that an NP can do just as good of a job as a physician in primary care, it's frankly insulting, and that affects burnout.
Giordano is a nephrologist and board member of Physicians for Patient Protection. She argues against the AAMC's proposal in a paper published in Annals of Internal Medicine. Primary care physicians have a unique relationship with patients that allow them to monitor a person over the course of their life and notice any deviations to a patient's normal baseline.
And I think people often underestimate the training that primary care physicians get. They go through 4 years of undergraduate training and then medical school, which is 4 years. And then on top of that, they undergo 3 years of either internal medicine or pediatrics or family medicine training to become a primary care physician. During those 3 years of residency, the average physician is accumulating around 10,000 hours.
Giordano herself recorded around 11,000 hours during training. PCPs work in both inpatient and outpatient settings, which gives them a full picture of healthcare that Giordano says is crucial for their role.
They're reading your notes. God forbid someone's hospitalized. They can read the notes of what happened to the patient while they're in the hospital and have an understanding fully what a subspecialist might be saying in those notes and what kind of follow-up would be required based on those prior experiences. Physicians have this shared language that develops over many years of talking about disease entities, testing, and general patient care. And that shared base knowledge allows us to have these extremely high-level conversations with other physicians to then render the care that the patient needs at the bedside.
On the other hand, the physician assistant program is 2 to 3 years of training, half spent in the classroom and the other half doing rotations through different clinical settings. Nurse practitioners need a master's or doctoral degree in nursing and often specialize solely in outpatient primary care. Education that makes them valuable but isn't the same as physicians. The breadth of knowledge that PCPs have also lets them treat conditions that many people would assume they need to see a specialist for.
For example, a primary care doctor can handle chronic kidney disease up to stage 3, the beginning of stage 3A, without needing to refer to nephrology. That's within all of our guidelines, and their knowledge base and purview is completely within their purview. And so that really helps alleviate subspecialists so that they're able to see patients who critically need them in that moment. And that saves patients time, money, energy, getting to know another clinician, and all those things.
That's not to say that non-physician practitioners are irrelevant. In fact, they're an extremely valuable member of the healthcare team. But Giordano doesn't believe their role can effectively replace what primary care physicians do. And though it's been proposed as a good fix for the physician shortage, a 2022 study offers strong evidence against this idea. The research, published in the Journal of the Mississippi State Medical Association, examined the Hattiesburg Clinic, the state's largest multi-specialty clinic. It decided to use advanced practice providers, like nurse practitioners, to fill their PCP shortage. And though there was still some collaboration with doctors, patients were mostly seeing the non-physician practitioners. But instead of having a seamless transition, the internal study reported that this model didn't provide patients an equal value-based experience to having a PCP.
What they found was that physicians saved the patients money because they were less likely to refer to the ER, less likely to refer to subspecialties, less likely to order certain imaging. And so ultimately, it saved the system a significant amount of money over the course of a year, somewhere upwards $10 million, because of the differences in how physicians are able to take care of patients more broadly and increased complexity.
The data shows that patients spent over $100 more a month when seeing a non-physician provider. Again, Giordano isn't arguing against the value of nurse practitioners and physician assistants. She's saying that the system functions the best when all the pieces of a care team work together instead of replace each other.
We need to have a structure that allows for both primary care physicians and NPs and PAs to work together collaboratively to render that care. I think that there should be protocols that say every X number of visits, the patient sees the physician. So in my role as a nephrologist, I did use a nurse practitioner, and every other visit, depending on your severity of chronic kidney disease, was with the nurse practitioner. And she and I checked in about each patient. So I knew what was going on with all the patients, but it did allow me to see more patients than I would have otherwise been able to do. But I think it's important for the physicians to have an active role and for that relationship to be a very open, conversational, daily touch point about what's going on with patients, so that if there's any questions that NP or PA has, they can feel free to raise them, and the physician has ample opportunity to address any potential concerns.
One argument in favor for using nurse practitioners as a PCP replacement is that it'll help open up the doctor's schedules to focus on the most dire patients. And though burnout may be one factor of the PCP shortage, Giordano doesn't think that having non-physician practitioners step into that role will help. In fact, it could increase rates of burnout for both communities.
I think opposing that, well, NPs and PAs can take the less complex issues so the physicians can focus on the complex patients, that contributes to burnout, because now I go from seeing 20 complex and non-complex patients, maybe alternating, right, to seeing 20 only complex. And that is very difficult. So this all comes down to ultimately the reason why we don't have a primary care solution is because the primary things that cause burnout in physicians still cause burnout in nurse practitioners and PAs, because ultimately we're all people. And it is very hard going to a job every day and feeling underappreciated and overworked and working, quote unquote, in your pajamas. We have pajama time. That's to talk about charting at night and being inundated by patient messages that are not reimbursed, et cetera, et cetera, et cetera.
As a final response to this proposal, Giordano writes in her paper, "More research is not needed. This experiment has been done and it has failed." Still, despite the evidence, it continues to be part of the PCP shortage conversation, which worries Giordano about the future of care Americans will have access to.
I worry that we are headed for, and have probably already started, a very two-tiered system where patients who are at risk for having adverse health outcomes because of their socioeconomic status, because of their race or ethnicity, that those, or insured status, that those patients are the ones who are going to end up with getting care exclusively by nurse practitioners, Ps, and won't have access to physicians, and that those who do have ability to pay will be able to see physicians.
A possible reality that, if it comes true, will only worsen our country's current health disparities.
Until patients are able to advocate for themselves, until organizations come out and say this is a disparity issue, we're going to start to see that widen and get deeper. Physicians are organizing themselves already. We say to each other constantly, I need to get a lot of friends in different specialties so that if something happens to me or my family member, I'm taken care of, my family member's taken care of. I don't know how people who don't have a family member who's a physician, I don't know how they're going to be able to access physician-led care. And that to me is very, very frightening.
You can find more information about Dr. Kristen Giordano and all of our guests on our website, radiohealthjournal.org. For more behind the scenes, follow Radio Health Journal on Facebook, Instagram, and X. Our writer-producer is Kristen Farah. Our production manager is Jason Dickey. I'm Greg Johnson.